Our first speaker will discuss about the context or roles of DFIs in health sector and debt crisis. She is an associate professor in politics at the University of Wollongong in Australia. She lectures in the areas of development, international politics, and political economy. She has co-authored a book with AR Bazbauers on the global architecture of multilateral development banks, a system of debt or development, a 2010 book on the World Bank in Southeast Asia, and over 30 journal articles and chapters. She is currently researching multilateral development finance, development cooperation between the nations of the global south, the role of emotions in the development, in particular in sanitation and microfinance, and teaching and learning in international studies. She worked in the government, community, and aid sectors before becoming an academic. She has volunteered with Indigo Foundation, a nonprofit community development NGO, since 2002. Let us all welcome Dr. Susan Engel.
So I'm going to, just while Jen's getting that set up, I'm going to talk a little bit about some of the broader context that Carlos touched on in terms of particularly what the multilateral development banks, the scale of their lending. I'll focus in on the Asian Development Bank, and then talk a little bit about the health sector lending from some research that I've done as well. So hopefully there'll be a little bit of overlap too with Vijay's presentation in a minute. If we could go on to the next slide, that would be great. So here's some data, a little bit similar to Carlos' points, but you can see the relative scale of World Bank group lending. They're aiming for 157 billion in the 15 months, I think it's a 15 months to July actually, which was a 60% increase on the 15 months prior to the pandemic. One of the, I guess, positive sides of that is the relatively high allocation to the bank's most concessional arm, the International Development Association, with about a bit over 53 billion of that 157 billion. But when you go down from that, you see the bank's private sector lending arm is being allocated a huge proportion of the response, and that's quite a change and very much reflects, I think, David Malpass's private sector lending agenda and the billions to trillions agenda of Kim Young Jim before him. The development banks have also been doing a lot of co-lending. The AIIB, its COVID-19 crisis response facility, they're aiming to get 13 billion between April 2020 and April 2022. And they've been doing quite a lot of co-lending, like for example, with the World Bank in India, that was quite common, but also with the Asian Development Bank. So sometimes if you're looking for information about AIIB loans, they're not disclosing a lot, but they're co-financing loans that you might get more information from on the World Bank or the Asian Development Bank site. The New Development Bank is also aiming for $10 billion under its COVID program, and the Asian Development Bank, the CARES program, that's our focus today, 20 billion in that, and a further 9 billion in the vaccine facility. The World Bank focus is supposedly targeting the health emergency, strengthened health systems, protecting the poor and vulnerable, supporting businesses, creating jobs, and promoting a green, resilient, and inclusive recovery. Next slide, please. This is the ADB CARES program, and so that $20 billion includes just 2.5 billion in concessional financing and 2 billion earmarked for the private sector. So both elements way less than the World Bank's equivalent kind of operations. You can see from the data here that Southeast Asia has been the biggest beneficiary so far with 8.5 billion. This is ADB data, by the way, not IAP data, which I probably should have used. So sorry about that, team. But it's the most up to date from them. So by region, Southeast Asia, South Asia, Central and West Asia, and then way down the scale there, the Pacific and East Asia. And you can see in terms of modalities, loans dominating, but guarantees at getting on towards 5 billion. That's fairly large, but just $500 million in grants. What I think is most interesting about the ADB Cares is the relative lack of focus on health. I think that reflects its historical limited engagement in the health sector. So just 1.72 billion directed specifically to health, contrasted to over 12 billion to public sector management and 6 billion to finance. Just following on from Carlo's points about the big concerns about these loan programs, as he pointed out, the first 2 points, the first 2 issues are really the lack of accountability and transparency. The rapid rollout of the funds meant a lot of this loan documentation has been fairly thin. And so there's some issues there. But there's a few extra points I'd add. One is that I think there's big questions about whether the ADB Cares and other DFI lending is sufficiently pro-poor and gender sensitive, and whether the livelihood support that is going out has too much conditionality. And finally, on debt issues, and I think Hassan, that's a particular focus of his work on Bangladesh, how debt levels are constraining the response of countries in the global south. And then, of course, the MDB lending, the development finance lending, will expand and exacerbate debt problems, and that debt will only further constrain the policy space for governments. In contrast, crises are always a boon for development banks. So, they, in fact, their lending goes up dramatically, and that's a boon for their flow-on programs for the next number of years. Next slide, please. So I've done some research for Jubilee Australia with Nadine, who's organised today. Thank you, Nadine, and Owen Williams. And I've also done some research that'll be coming out shortly for Public Service International. Most of this is focused on healthcare. The PSI research is on the Indian context, and the Jubilee research we did was on Indonesia and Sri Lanka. And I'd say that what it shows overall really in terms of healthcare is that decades of the neoliberal thinking applied to healthcare has left quite an emaciated public health system in the global south that are generally really ill-suited for responding to pandemics. And what I've outlined in this slide here, but I didn't want to go through in any depth, was just what I think are some of the key phases in how that neoliberal agenda was applied to the healthcare sector through corporatization, the introduction of private providers, segmenting the healthcare market and segmenting and privatizing segments of the healthcare sector, the health insurance, and just the overall transfer of responsibility. So turning specifically to the COVID loans, and next slide, please, is that there's been some research on the International Financial Institutions response to COVID-19 that said that it's a continuation of using crisis as an opportunity to push through reforms, like, in the sense of Naomi Klein's shock doctrine thesis. What I think we've seen in the healthcare sector is really not so much that crisis as an opportunity for new reforms, but what's equally concerning are very much business as usual, some further privatisation, but a business as usual continuation of the already neoliberalised healthcare agenda. So the next point, I think, is that the overall response in healthcare simply hasn't been strong enough. And you see that with the ADB Cares priorities, that healthcare really, for example, wasn't even high enough on that list. The policies from the development banks just favoured continued commercialisation and privatisation of healthcare. And that's despite the fact that there's so much evidence now about the failures of privatisation in healthcare, that it's basically more expensive and less effective than public healthcare. But despite that, in the midst of a crisis, the development banks have continued their agenda of promotion of a increasingly privatised healthcare sector. Bank loans are seemingly going mostly to, development bank loans are seemingly going mostly to the government. But because in so many countries in the global south and in some in the global north as well, that the healthcare sector is so privatised, the loans are flowing through to the private health sector. They have to, in order to have enough beds to respond to the crisis. So, so we know that those loans are going both directly to private providers and indirectly. And some of those private providers have needed the finance to keep them afloat because the pandemic was in fact a challenge to the privatised healthcare model. People were cutting back on elective surgery and non-urgent surgery. And so it's really challenged the private provider profits. Some of private providers have needed support from governments and from development finance institutions to keep them afloat. And that's particularly something we talk about in the paper with Nadine and Owen for Jubilee Australia. At the same time, the loans don't address the many failures of private providers in the wake of the crisis, that they've been price gouging, they've provided often poor standards of care, or they've refused to treat the poorest patients or those from the lowest caste or class, etc. The high levels of funding for the International Finance Corporation, and in particular in the World Bank, are of concern because, like mainstream bank loans, there's no conditions to ensure that those private firms getting support treat the poor and the vulnerable to ensure that those groups have access. The IFC have also been making lots of investments and loans in the healthcare sector to financial intermediaries and investment funds. And as you all know, those are even less transparent than normal bank lending. It's really hard to track when they're investing into investment funds that will fund the private healthcare sector. Finding where that money went is really difficult. So what we're seeing overall is really an expansion of healthcare financialisation, but through this business as usual sense. I think one of the other conclusions I take out of the COVID loans and the COVID pandemic is that health insurance has often proved useless in this context. This is because, particularly for rural people who don't have access to private providers within a reasonable period, for example, or in urban areas where private providers will prioritise those with more resources. And the insurance-based universal healthcare models where it's operating still leaves people with large debts. And those out-of-pocket expenses are one of the key forces pushing people back into poverty or into poverty for the first time in the COVID context. There's been inadequate attention to the pandemic on the inequality in healthcare access based on location, class, caste, gender, and so on. And that is a really big failure of the MDBs in this area, I would say. So my final point is I just think there's a neoliberal meta-narrative going on here that perhaps, if anything, was reinforced by the crisis. That, you know, I'm quite interested in the literature on how we make decisions, our decision-making processes and heuristics. And I think what we see is that the experts just relied on in the development banks, relied on their standard ways of thinking about healthcare. And even though it was manifestly inadequate in the wake of the pandemic, and we see that with the lending. And that's it for me.